So now we've finished the chapters covering specific families and genre of organisms. So the next set of chapters we'll be discussing cover the actual infections caused by the various bacteria that we've discussed so far. These chapters fall under Part 3 of your textbook, the Laboratory Diagnosis of Infectious Diseases and Organ System Approach to Diagnostic Microbiology. So Chapter 33 discusses skin and soft tissue infections. So one important thing to know as we're talking about this chapter, we're looking at these skin and soft tissue infections from a bacterial standpoint, because remember, there's other organisms that can cause skin infections, such as fungi, mycobacteria, and viruses. But again, we'll just be looking at the organisms we've seen so far. So one thing that's important to remember that we already saw in immunology is that the skin is the body's first line of defense against microbial invasion. The skin serves as a physical barrier that continually undergoes epithelial cell turnover. So the cells are removed along with substances that could potentially cause infection on the surface. Remember, the skin is also colonized with a variety of resident microbial organisms, and these also serve a protective function. Before we discuss the specific types of infections, we'll revisit the anatomy of the skin. So remember, the skin consists of 3 layers: the epidermis, the dermis, and the subcutaneous layer. The epidermis is the outermost layer, and it's composed of several layers of epithelial cells. The outermost layer of the epidermis contains dead cells consisting of a protein called keratin. The second layer of skin is the dermis, and this is a thick layer composed of connective tissue. Sweat glands, hair follicles, and oil gland ducts are found in the dermis. These structures are the potential passageways through which microbial organisms can enter the skin. The structures such as sweat glands and oil glands that serve as potential passageways also have protective functions. So sebum and perspiration provide moisture and nutrients necessary for the growth of certain microbes. The salt and lysosomes contained in perspiration and fatty acids found in sebum can inhibit the proliferation of other pathogenic microorganisms. So we'll revisit this diagram showing the anatomy of the skin, and we saw a similar figure in immunology. So skin consists of the 3 layers, the epidermis and the dermis, which we discussed. And again, the sweat ducts, the hair follicles, these serve as passageways for microbial organisms to enter and cause potential infection. And as was mentioned, and we know, the skin also has normal flora or skin biota that protect the surface and don't necessarily cause infection unless someone becomes immunosuppressed. The skin itself is not a particularly inviting environment for microorganisms, but the normal flora are able to adapt to high salt concentrations, exposure to the elements, and a relative lack of nutrients and moisture. These normal residents of the skin are usually a small and stable array of bacteria and fungi, and it's also been seen that they may act as competitive inhibitors against pathogenic organisms. And also, as we've seen and know, breaks in the skin in this first line of defense allow both normal flora of the skin, such as staph species, to cause infection, and also allows more transient organisms to enter and cause disease. Important members of the skin, normal flora, that can commonly act as agents of skin infection include gram-positive cocci, in particular Staphylococci and Streptococci. Coagulase-negative staph, such as Staphylococcus epidermidis, are permanent skin residents. whereas Staphylococcus aureus, which is coagulase positive, is a transient colonizer. Other members of normal flora include diphthoroids such as Propionibacteria acnes and Corynebacterium, along with yeasts such as Candida. Although vigorous washing reduces the amount of surface skin normal flora, it will not completely eliminate resident microbiota colonization. The acidic pH of skin, with it being about 5, also inhibits many common skin pathogens. An extensive list of infections can involve the skin, but bacteria are the cause of most skin infections, and they have become more difficult to treat in recent years because of increased antimicrobial resistance. Staphylococcus aureus is one of the major causes of skin infections by bacteria, and this is also an organism that has developed resistance. So we know MRSA, or methicillin-resistant Staph aureus, is an organism of concern. Other bacteria that display multi-drug resistance include Pseudomonas aeruginosa, Enterococcus, beta hemolytic strep, E. coli, and Enterobacter species. Table 33.1 in your textbook shows the results of a survey of causative agents of skin and soft tissue infections isolated from patients in North America. So, of course, this study was taken from isolated areas, so the numbers seem low in comparison to the national numbers. But as you can see, Staphylococcus aureus is one of the top pathogens isolated. And this organism has become resistant to many common antimicrobials, and it accounts for almost 45% of over the 5,800 isolates that they looked at in this study. Pseudomonas aeruginosa displays multi-drug resistance, and it's ranked second at 11% in the study. And then other less common gram-positive bacteria included Enterococcus and beta hemolytic strep. E. coli and Enterobacter species were some gram-negative rods that were isolated through the course of this study. Skin and soft tissue infections can be classified in multiple ways. One method classifies them as per their appearance of the skin lesion, and this provides an important clue about the possible causative agent. Skin and soft tissue infections can also be classified as they are discussed in this chapter according to whether they occur as a manifestation of either systemic disease or as a primary skin process. The primary skin infections can then be further classified by the skin and soft tissue structure affected, and then further subdivided by the causative agent. It is important to note that a variety of the pathogens may cause infection by gaining access to the skin as a result of another pre-existing skin condition. Table 33.2 in your textbook provides a summary of infections secondary to pre-existing skin lesions. It also provides the major pathogens that are the causative agents for each type of infection. So, for example, with surgical wounds typically being sterile sites, the causative agent would usually be Staphylococcus aureus or some gram-negative bacilli. But with contaminated sites, specifically such as the colon, a surgical wound infection would more commonly be caused by Enterobacteriaceae and anaerobes, along with Streptococci or even Staph aureus. Intravenous infusion sites, both surgical wound infection and trauma infections, typically would be caused by normal skin colonizers such as Staphylococcus aureus. The table also lists some of the more unique organisms, such as Aeromonas or Plesiomonas, that would be associated with freshwater contaminated trauma sites, or Vibrio or Mycobacterium marinum that would be associated with saltwater contaminated trauma sites. In addition, some of the other organisms we saw that can cause skin infections include human oral aerobes and anaerobes, along with Staph aureus, and then the dog, cat, or rat-associated bites. So with dogs and cats, we know that Pasteurella is a common organism that might be seen. Also Capnocytophagia. With rats, Streptobacillus moniliformis and Spirillum minus are organisms more commonly associated with rat infections. And finally, other types of secondary skin infections include those associated with immunosuppressed patients, such as decubitus ulcers or bed sores, or foot ulcers. So these are usually associated with diabetics. And then, of course, with burns, you can have various organisms. But as you see from each of the categories or in the infections, a major pathogen always is Staphylococcus aureus. So in this chapter, we're looking at the clinically important and prevalent infections of the skin and soft tissue. And first we'll look at those that occur in localized areas of the body. So the way the textbook is divided, it's presented from the most superficial and localized infections to the deeper, more serious infections that then can become systemic. The textbook covers bacterial, fungal, and some other organisms as well, but like I mentioned before, we're going to be looking primarily at the bacterial causes of these skin infections. The first group of infections we'll be looking at are those that include dermatitis. So dermatitis is a general term, and it describes an inflammation of the skin, and it's characterized by areas of redness, swelling, and sometimes scaling of the skin. Dermatitis is often accompanied by pruritus or itching. There's many causes of dermatitis, and only some of them are associated or related to infection. So again, we'll be looking at the most common infectious causes of dermatitis and focusing on bacteria. The first presentation of dermatitis we'll discuss is Erythrasma. So this is a superficial chronic skin infection that manifests as an itchy reddish-brown rash. The rash appears scaly and wrinkled and usually occurs on the groin, inner thighs, and webs of the toes. It occurs most often in men, obese individuals, and diabetics, and is generally a localized and benign infection. Corynebacterium minuticium is a normal skin biota resident, and this is the causative organism of this infection. It can be observed as filamentous gram-positive rods with a gram stain taken from various samples. Topically administered erythromycin or clindamycin or orally administered erythromycin are useful in the management of erythrasma. So erythrasma is the only dermatitis we'll talk about that primarily involves a bacteria. The others discussed in the textbook are caused by various fungi, which we'll cover later on. So the next group of skin infections we'll talk about are Pyodermas. So these are a group of inflammatory skin disorders caused by bacteria that produce pus. The terms Impetigo and Pyoderma have been used interchangeably. It's important to note that there are other forms of pyoderma that are discussed later in the chapter, but we'll be looking at those caused primarily by bacteria. So the common primary pyodermas are ones we've already seen, such as Impetigo, caused by Staph aureus or group A strep, Cellulitis, that can also be caused by strep pyogenes, group A strep, or Staph aureus, along with folliculitis, furuncles, carbuncles. So these are all infections that we've seen also caused by Staph aureus, and we'll talk about each of these in a little more detail on subsequent slides. So the first pyoderma we'll talk about is Impetigo, and this is a common one, most often seen in children. Most cases were caused by group A strep, so that's Streptococcus pyogenes, although Staph aureus has become a predominant pathogen over the last 15 years or so. And there has also been an increase in the frequency of methicillin-resistant Staph aureus. Impetigo is common in hot and humid climates, and it's also highly contagious, particularly in areas of crowding or poor hygiene. Initially, the lesions of impetigo begin as small vesicles that become pustules that rupture. The discharge is thick and yellow and then dries to form a classic golden crust. The lesions are superficial and painless and do not scar. They can be itchy and easily spread by scratching. The Bullous form of impetigo accounts for about 10% of cases, and this is caused by strains of Staphylococcus aureus that produce exfoliative toxins, leading to the formation of bullae, which quickly rupture and form transparent light brown golden crust. The diagnosis of impetigo can be made from a gram stain and culture of the vesicular contents. So this figure shows an example of Bullous impetigo caused by Staphylococcus aureus. So you can see here is the formation of a bullae produced by the exfoliative toxins. So this is one that hasn't ruptured yet. And then here you have an example of a ruptured lesion, and then it has the crust that's formed after the rupture. Erysipelas is the next type of pyoderma we'll discuss. This is a type of superficial skin infection that involves the epidermis and the underlying dermis and lymphatic system. It's usually seen in children and older adults. The infection typically occurs on the face, but sometimes can be seen in the lower extremities. The lesions of Erysipelas are characterized as painful, indurated areas of inflammation with raised borders that are sharply demarcated from the adjacent normal skin. The involved skin usually has a bright red to crimson hue, and patients often have fever. Most uncomplicated cases remain confined to the dermis and the lymphatics, but deeper extension can occur with cellulitis, along with abscess formation or necrotizing fasciitis. Bacteremia can also occur in a minority of cases, and it can make this infection potentially life-threatening. Most infections are caused by group A strep, Streptococcus pyogenes, with some infections being caused by other beta-hemolytic streptococci and Staphylococcus aureus. Erysipeloid varies from Erysipelas because it's a superficial soft tissue infection caused by a specific organism. So this is caused by Erythrapelothrix ruseopathiae. This infection is an occupational hazard of handlers of animals, meat, poultry, hides, and saltwater fish. The organism is typically introduced by trauma, so the fingers and dorsum of the hands are the most frequent sites of infection. This infection does mimic Erysipelas with lesions that are red and painful with raised borders. Septic arthritis and bacteremia may occur as a complication of this infection. It's important to remember too, as we're going through this chapter, the different causative agents of these skin and soft tissue infections, also remembering how they present in culture or laboratory testing to diagnose them. So remember, Erythropelothrix ruseopathiae is a gram-positive rod, whereas the causative agents of Erysipelas are gram-positive cocci. This figure shows an example of Erysipelas caused by Staphylococcus aureus. So here you can see the characterized rash. So there's a painful indurated area of inflammation and the raised borders caused by the infection. So usually diagnosis is actually based on clinical presentation because it's difficult sometimes to isolate the organism from the skin lesions. So the next type of pyoderma we'll discuss is caused by Bacillus anthracis. So remember, this is the agent of anthrax, and it's a gram-positive rod, and it can cause pulmonary and systemic infection, but it also can cause ulcerative skin lesions. So the cutaneous form of anthrax is more commonly seen than pulmonary or systemic infection. Remember, these skin infections or the skin lesions occur most often in wool handlers or persons working with animal products that are contaminated with the spores. Anthrax skin lesions are usually seen on the face, neck, or arms at sites of minor abrasions, and they begin as painless papules that vesiculate and are surrounded by a significant redness and a type of edema. The vesicles then evolve into hemorrhagic and then necrotic lesions and form that black eschar. The skin lesions often remain painless. Diagnosis is often suspected clinically given the characteristic skin lesion and the patient history, but biopsy and culture should be performed for confirmation. Remember, isolating Bacillus anthracis from a clinical specimen constitutes a critical value, and it should be communicated to the patient's health provider immediately. This infection is uncommon in the United States, and like we discussed in our bioterrorism chapter, if there's a suspected isolate, you should be ruling it out and not doing a full identification or workup. The next few infections we'll talk about continue along the line of Pyodermas, but we'll be focusing on the causative agent of Staphylococcus aureus or methicillin-resistant Staphylococcus aureus. So cellulitis is a diffuse inflammation and infection of superficial skin layers and subcutaneous tissue, and it's a common form of skin and soft tissue infection that accounts for many hospitalizations and physician visits each year. Cellulitis extends deeper in the soft tissue than Erysipelas, and it appears as an area of painful redness with warmth and edema of the skin with poorly defined margins. Drainage of pus from areas of cellulitis may also occur, and these cases are usually caused by Staphylococcus aureus. Depending on the severity, cellulitis may be accompanied by fever. Infection is usually as a result of surgery or trauma to the skin. The most common causative agents of cellulitis are Staphylococcus aureus and group A strep, although there are some other beta hemolytic streps that can cause cellulitis. Recurrent cellulitis infection can occur in patients who have underlying health problems, such as lymphedema, obesity, venous stasis, and untreated tinea pedis, which is a fungal infection. So these are associated with increased risk of developing recurrent skin and soft tissue infections. Aside from Staphylococcus aureus being a causative agent of cellulitis, MRSA, or methicillin-resistant Staphylococcus aureus, is one of the most common causes of skin and soft tissue infections in the United States. MRSA is common in the hospital setting, and it actually accounts for almost 50% of the Staphylococcus aureus isolates. The proportion can actually be as high as 64% in intensive care units. Although hospital-acquired MRSA is of concern, it's also important to note that there's been studies and surveys showing that community-acquired MRSA cases have also been seen to be on the rise in the United States. Other skin infections that involve Staphylococcus aureus, along with some other organisms, include various that we've discussed previously. Paronychia is an infection of the cuticle surrounding the nail bed. So cases of this infection generally occur after minor trauma, such as removing a hangnail. The involved part of the finger at the nail margin then becomes painful, red, warm, and swollen, and pus may be expressed from around the nail bed. The causative organisms are typically Staphylococci or Candida. Folliculitis is an infection we already saw previously in our chapter in covering Staphylococcus. So this is inflammation and infection of the hair follicles. So as you can see, Staphylococcus aureus is a causative agent, along with Pseudomonas aeruginosa. In immunocompromised hosts, Candida can be the causative agent along with Staphylococci. Furuncles occur when folliculitis progresses to form deeper inflammatory nodules. Certain individuals are more inclined to develop furuncles, such as diabetic patients, obese patients, or patients with defects in their immune function. Furuncles are initially red and firm, but soon they become painful and generally drain spontaneously. Staphylococcus aureus is the most common causative pathogen. They can usually be managed by application of moist heat to accelerate drainage, although sometimes antimicrobial therapy may be needed. So here's an example of folliculitis that progressed to a furuncle. So a hair follicle on the breast probably began as folliculitis, and then it progressed to this furuncle, the larger, deeper inflammatory nodule. A carbuncle is a more serious lesion, and it extends into the subcutaneous fat. It consists of multiple abscesses that can drain at several adjacent sites along hair follicles. Carbuncles commonly occur at the nape of the neck and on the back of the thighs and are often associated with fever and systemic systems. Bacteremia can occur as a complication, and surgical drainage is needed for most carbuncles. Typically, Staphylococcus aureus is the causative agent of carbuncles. And the last pyoderma we'll discuss before we go into the other soft tissue infections is Hidradenitis suppurativa. So this is a difficult to treat recurrent infection of the apocrine sweat glands. So these sweat glands are usually associated with hair follicles in the armpits and the pubic regions. This infection manifests as nodular, tender, red swellings that become full and then drain. They're often associated with fever and tender lymphadenitis. Staphylococcus aureus is a causative agent, but various other organisms can be involved in this infection, including streptococci, gram-negative bacteria such as E. coli and Pseudomonas, and anaerobic bacteria. This infection is usually accompanied by scarring of the involved areas. A combination of broad-spectrum antibiotics based on culture results and frequently surgical incision and drainage are needed to treat this type of infection. Other soft tissue infections that can occur are as a result of bites. Infections may happen as a result of either human or animal bites. These infections are commonly associated with both aerobic and anaerobic pathogens. So, for example, human bite infections may be caused by Staphylococcus aureus, Streptococcus anginosus, Eikenella corrodens, Fusobacterium nucleatum, and Prevotella meningogenica. So some of these organisms, such as Staphylococcus aureus, are colonizers of the nasopharyngeal tract or even the skin, whereas others, such as the Streptococcus, Eikenella, Prevotella, these are normal flora of the oropharyngeal tract of humans. Animal bite infections include some different organisms that are associated with specific animals, such as dogs having Pasteurella, Bacteroides, or Capnocytophagia being the causative agents of infection, and usually dog bites are polymicrobial, so they may involve these organisms listed along with several others. So these lists with the animal bite infections and the humans as well are not all-inclusive. Cat teeth can also inflict deep wounds and have greater risk of infection, soft tissue abscess formation, and infection of underlying bones and joints compared with dog bites. Cat bites also progress to infection more rapidly than dog bites. So pathogens associated with cat bites include Pasteurella multicida, Bacteroides, Fusobacterium, Porphyromonas, and then some Staphylococci. Foot infections associated with diabetics are a common occurrence that account for other soft tissue infections. Risk factors for foot infection include the presence of peripheral neuropathy, trauma to the feet, inadequate blood glucose control, compromise of the peripheral vascular circulation caused by diabetes, impairment of kidney function, and improper foot care, including walking barefoot. Diabetic foot infections can progress to cellulitis. So these are typically caused by streptococci or staphylococci, as we saw when we discussed cellulitis. Acute or chronic soft tissue ulceration can occur, and this can be with or without underlying bone infection. And finally, gas gangrene can occur as a result of the initial foot infection, and this can be caused by various organisms and is usually of mixed infection, but it can include staphylococci, streptococci, and then other bacteria like Enterobacteriaceae, Pseudomonas, gram-positive organisms, and anaerobes such as Clostridia, which we saw in our anaerobe chapter. It's important to remember that the impairment of host defenses seen in diabetic patients can also allow weakly virulent organisms such as coagulase-negative staphylococci and dipteroids to become pathogens in the skin as well. In this figure, the patient has a foot infection who's diabetic, and you can see the gas formation in the areas marked by the arrow. Infections that produce tissue necrosis and soft tissue gas represent an important subset of skin and soft tissue infection cases. These infections can rapidly progress and are frequently life-threatening, and they can be classified according to their level of soft tissue involvement, whether it's superficial, epidermal, or dermal structures, along with fascia or muscle. They're also classified according to the causative microbiologic agent. Remember, we discussed previously there's subtypes of necrotizing infection. So there's type 1, that's a polymicrobial necrotizing fasciitis, typically caused by Enterobacteriaceae and anaerobes. Type 2 is a monomicrobial necrotizing fasciitis, usually caused by group A strep, Streptococcus pyogenes. And then there's the type 3 gas gangrene, that's known as Clostridial myonecrosis, and this is caused by Clostridium species, specifically usually Clostridium perfringens. The most common form of necrotizing soft tissue infection is type 1. So this is a polymicrobial infection, and it tends to occur in the trunk and perennial region of patients who have underlying medical illnesses such as diabetes or who are immunosuppressed. Patients with type 2 infections caused by group A strep tend to be younger and previously healthy, and infections more often involve the extremities. Type 3 infection caused by Clostridia is now unusually uncommon, but the toxins produced in this Clostridial myonecrosis contribute to extensive soft tissue damage. This usually occurs in contaminated wounds when medical treatment is limited. Mycetoma is another type of soft tissue infection that's a chronic skin and subcutaneous infection caused by either bacteria or fungi. Infection is known as actinomycetoma when it's caused by bacteria. So the organisms we've seen previously include Nocardia and actinomyces that can cause this infection. The other causative agents such as Madura, Aspergillus, Pseudoscheriae, Boidiae, these are all fungi that we'll discuss in later sections. Usually infection occurs as a result of skin trauma with an object contaminated with the organism. Another name for mycetoma is also known as Madura Foot, and it's characterized by localized swelling and abscess formation within the subcutaneous tissue, and the development of sinus tracts with visible granules. They're formed by aggregates of the organisms in the pus draining from the fistula. The disease progresses slowly and is destructive with extension to muscles and bone. Soil and decaying vegetation are reservoirs for the causative agents of this infection. So the disease is usually seen in outdoor laborers and may be as a result of lack of protective clothing, including shoes. This figure shows an example of Madura Foot. So this is Mycetoma of the foot. So here you can see the local swelling and the abscess formation. And this infection is more commonly associated with the foot, but it can occur in other sites such as the hand, shoulder, back, and sometimes very rarely the face. So Madura Foot or Mycetoma is rare in the United States, but it's common in tropical and subtropical regions of the world, especially where people go barefoot. So the next few causative organisms we'll discuss cause more systemic infection, and then the last group we'll talk about are those causative agents of purely systemic infections. So nodular lymphangitis or lymphocutaneous syndrome is an inflammatory infection in which nodules occur along the lymphatic vessels that drain to areas of primary skin infection. So this infection is associated with a couple organisms, some being fungal in origin, while others are bacterial. So Nocardia is one of the organisms that we've looked at before. So this figure is an example of nodular lymphangitis caused by Sporotrichosis. So this is a fungal organism, but just to give you an idea of the clinical presentation of nodular lymphangitis. So, as I mentioned, there's various agents of this infection, including fungi, parasites, mycobacteria, and viruses, but the main bacteria we're looking at are Nocardia, and then other ones that can cause this infection include Staphylococcus aureus, Francisella tularensis, and Bacillus anthracis. Nocardia species are found in various areas in nature and the environment, such as soil, water, and vegetation. And they're part of the aerobic Actinomycetes group. So remember that includes Corynebacterium, Rhodococcus, Gordonii, along with Mycobacterium. So Nocardia are the causative agent of Nocardiosis, which can be transmitted by direct cutaneous inoculation. Infection can be localized or disseminated, with disseminated infection occurring more often in immunosuppressed patients. In the skin and soft tissue forms of Nocardia infection, manifestations can range from lymphocutaneous syndrome, such as seen in the previous figure, to subcutaneous abscesses, cellulitis, and mycetoma. Actinomycosis is a chronic infection caused by actinomyces, with the primary causative agent being Actinomyces israelii. It's characterized by formation of abscesses, tissue fibrosis, and draining sinuses that discharge sulfur granules, which are masses of the Actinomyces organisms. Remember, Actinomyces is a non-spore-forming anaerobic or microaerophilic bacterial species. It was once thought to be fungi because of the branching appearance. And these organisms can be found as normal flora of the mouth and gastrointestinal and genital tracts. So again, disease is usually involved with immunosuppressed patients. Here is an abscess formed as a result of Actinomyces infection of the jaw following a dental procedure. So the next group of infections we'll look at are systemic infections that can produce skin lesions, and these lesions can provide important diagnostic clues. So these dermatologic manifestations are not necessarily a primary skin infection itself, but appear as a result of the infection systemically. So again, in this lecture, we'll be focusing on the bacteria that cause these systemic infections and dermatologic manifestations. So the first one we'll look at is Pseudomonas infection. So the dermatologic manifestation is known as Erythrasma gangrenosum, and it's a characteristic skin lesion associated with Pseudomonas bacteremia. So it's a result of bacterial invasion of dermal blood vessels leading to ischemia, hemorrhage, and necrosis. So it's usually associated with Pseudomonas sepsis. Of note, although classically associated with Pseudomonas species, lesions have been reported in sepsis caused by other gram-negative bacteria, along with Staphylococcus aureus and Candida. Patients with Vibrio vulnificus sepsis can also develop skin lesions that are widespread. They're characterized by the formation of hemorrhagic bulli that evolve into ulcers and skin necrosis. Infection occurs through ingestion of contaminated shellfish, such as raw oysters, or exposure of an existing wound to seawater containing the organism. The patient then progresses to sepsis, and then these characteristic lesions can be observed. Aeromonas species, similar to Vibrio, can cause skin lesions. Aeromonas species are found in freshwater and brackish water. Skin infection due to Aeromonas is often the result of contamination of a pre-existing wound with water containing the organism. Aeromonas infections can be complicated by bacteremia and sepsis. Patients with underlying liver disease are at higher risk for invasive Aeromonas infection. Skin infection is typically rapidly progressing with formation of hemorrhagic bulli and skin necrosis. Aeromonas infection is also a well-recognized complication of medicinal leech therapy used in reimplantation or flap procedures, because aeromonads are symbionts within the gut of leeches. In Lyme's disease caused by the tick-borne spirochete Borrelia burgdorferi, a characteristic distinctive bullseye or target skin lesion called erythema migrans can be observed at the inoculation site 1 to 2 weeks after infection. Over a period of weeks, multiple secondary erythema migrans lesions can occur in various regions of the body as the spirochete disseminates. In syphilis, Treponema pallidum can cause skin manifestations. In primary syphilis, the painless chancre can be observed in the genital area on men, whereas in women it's less frequently observed. In secondary syphilis, a diffused rash occurs, with involvement of the palms and soles being characteristic of this infection. There are several zoonotic diseases transmitted to humans by wild or domestic animals that have significant dermatologic manifestations. So with Lyme disease being one of them, we'll look at a few more. So some of them we've looked at a little bit, and some of them you may be seeing for the first time. Rickettsiosis infections are characterized dermatologically by the type and distribution of the associated rash. The observation of the presence or absence of a black eschar at the vector bite inoculation site also helps categorize and identify the causative agent of infection. Clinical symptoms common to rickettsia include high-grade fever, chills, malaise, headache, myalgias, rash, and involvement with the conjunctiva. Systemic and cutaneous disease manifestations are as a result of widespread inflammation of small blood vessels. So remember, rickettsia are gram-negative intracellular pathogens, and they will reside within endothelial cells and macrophages. They have various animal reservoirs and are transmitted to humans through several species-specific insect vectors. So there's the two general types of rickettsia, the spotted fever group and the typhus group. Rocky Mountain spotted fever, caused by Rickettsia rickettsii, is the most frequently seen infection in the United States, and it's transmitted by several types of ticks depending on geographic location. A maculopapular rash appears on the extremities about the third day after exposure, although many patients with Rocky Mountain spotted fever don't remember having been bitten by a tick. It usually starts at the wrists and ankles, and it involves the palms and soles and spreads rapidly to most of the body. Boutonese fever, also known as Mediterranean spotted fever, is caused by Rickettsia conurei, and this is characterized by the tache noire, the black spot or eschar at the site of the tick vector bite. This is an illness that's not endemic in the United States, but can be seen in travelers returning from areas such as India, Pakistan, Africa, and Eastern and Southern Europe, in areas around the Mediterranean Sea. The skin lesion is the result of endothelial injury in soft tissues with necrosis. Rickettsial pox is caused by Rickettsia acari, and this is also one of the spotted fever group forms of rickettsial disease, but it's transmitted by the bite of mites rather than ticks, and mice are usually the reservoir. Rickettsia acari does occur worldwide, but was actually initially found in New York City. Clinical findings include fever, rash, and black eschar, which develops from a papule that vesiculates. Leptospirosis is a zoonotic disease that we already looked at, caused by Leptospira interrogans, and this is a spirochete aerobic organism. Leptospira is carried in the renal system of rodents and other mammals, including dogs and livestock. So infection is associated with persons in contact with these animals' urine. Infection is found throughout the world, particularly in tropical and subtropical areas, and the highest incidence in the U.S. is actually in Hawaii. The rash associated with leptospirosis is maculopapular and may become hemorrhagic. Disease manifestation with leptospira infection varies to be self-limiting to a fatal infection with renal and liver failure involvement, along with pneumonia. Bartonellosis is one infection that we haven't discussed previously, but is an important one to remember because Bartonella is the causative agent of cat scratch disease. So Bartonella henselae is a gram-negative bacteria that usually causes self-limiting infections in immunocompetent individuals, but can cause potentially life-threatening infection in immunosuppressed patients. The two important species are Bartonella henselae and Bartonella quintana. So these are intracellular bacteria transmitted by insects such as sandflies, human body lice, and cat fleas, or by animal scratches or bites, hence the name cat scratch disease. The initial lesion of cat scratch disease is a papule, pustule, or vesicle, usually on the arm, followed by development of regional lymphadenopathy associated with fatigue, fever, and malaise. Infection can resolve spontaneously after weeks to months. But again, with immunosuppressed patients, it can progress to a more complicated form. Two bacterial diseases that are rare in the United States are included under the general description of rat bite fever. Streptobacillus moniliformis and Sporotrichosis minus can cause this infection. Infection presents with abrupt onset of fever and chills, headache, and muscle pain, and it's followed by a rash that can appear petechial, maculopapular, or pustular, and the rash mostly occurs in extremities. Rash associated with rat bite fever involves the palms and the soles, and with Streptobacillus moniliformis infection, but not Sporotrichosis minus infection, joint swelling and pain can often occur in association with the rash. Tularemia is the last zoonotic dermatologic presentation we'll look at. So tularemia is caused by Francisella tularensis, a gram-negative coccobacillus, and it can occur in several forms, including glandular, ulceroglandular, oculoglandular, pneumonic, and septicemic or typhoidal. The type and severity of disease depends on the strain of infecting bacteria, the dose, and the route of infection. Transmission can occur, as we've already seen, through contact with infected animals or contaminated water or soil, or from arthropod bites, with the most common form of the disease being the ulceroglandular, in which infection is inoculated directly into the skin after handling infected rabbits, rodents, and other wild animals. Infection presents as an indolent, painless ulcer, often on the hand, accompanied by swelling of the regional lymph nodes. Some patients can have nodular lymphangitis. Infection that manifests itself as lymphadenopathy without a report of an ulcer is termed as glandular. The other forms of tularemia occur through inoculation of the eyes or inhalation of the bacteria from the environment. All forms of tularemia may be associated with a maculopapular rash or vesicular rash and erythema nodosum. So the last group of dermatologic manifestations we'll discuss are the immune or toxin-mediated presentations. So we saw earlier there's various local and systemic infections caused by bacteria. So the skin lesions resulting from either direct cutaneous infection and those resulting from hematogenous spread to the skin have been described. So now the last section will cover dermatologic manifestations of infection that can result from the body's immune response to the infecting organism or from toxins produced by the organisms. During sepsis from any cause, dysregulation of the blood coagulation system can occur. Pro-inflammatory cytokines released in response to infection play an important role in disseminated intravascular coagulation, or DIC. Bacterial sepsis, such as that caused by Neisseria meningitidis, streptococci, or some other enteric gram-negative organisms, are the most common causes in which one would encounter infection-related DIC. The processes involved in DIC manifest as venous thrombosis petechia of the skin, thrombocytopenia, bleeding, and multi-organ dysfunction. An additional skin manifestation of DIC is purpura fulminans. So this syndrome has typically been associated with meningococcemia, but it's also been linked to septicemia with Staphylococcus aureus, Streptococcus pneumonia, and Haemophilus influenza, and it's characterized by rapidly developing skin hemorrhages and necrosis and peripheral gangrene. It's accompanied by shock syndrome. Many types of infections can trigger direct or immune-mediated damage to small blood vessels in dermal tissue, and this results in vasculitis, and it usually manifests as a palpable purpura, typically over the lower extremities. Cutaneous vasculitis has been associated with various organisms including Streptococci, Staphylococci, Legionella, Rickettsia, and Yersinia. Infection-related immune complex-induced cutaneous disease is often seen in endocarditis, with cutaneous purpura being the most common skin manifestation. In addition, these painful small skin nodules located on the pads of the fingers and toes, known as ossular nodes, may be seen with this type of infection. Staphylococci and Streptococci are typically associated with these skin manifestations, although it's been seen that gram-negative bacteria and candida may produce similar lesions. This figure shows an example of petechial lesions associated with meningococcemia. So remember, meningococcemia refers to Neisseria meningitidis infection. So with this infection, the bacteria may seed local sites such as the meninges, joints, or pericardium, or multiply in the bloodstream, causing meningococcemia with petechia. So the organism is found in the blood. The petechia are formed when the tiny blood vessels, the capillaries, break open. So when these blood vessels break, blood leaks into the skin. This figure shows an example of the immune-mediated damage to the small blood vessels in the dermal tissue known as vasculitis associated with endocarditis, and this figure depicts an infection associated with Staphylococcus aureus in particular. The last few presentations we'll look at involve toxin-mediated cutaneous disease. So certain bacteria, particularly Staphylococci and Streptococci, produce toxins that affect the skin, resulting in distinct clinical syndromes and dermatologic presentations. So they can start as primary skin and soft tissue infections, or may initially affect another site with subsequent involvement of the skin caused by the effects of circulating toxin. So certain strains of Staphylococcus aureus can produce exfoliative toxins that result in staphylococcal scalded skin syndrome. And this is a blistering skin condition most commonly seen in children less than 5 years of age. Scalded skin syndrome is characterized by fever, skin tenderness, and a scarlet form rash that resembles scarlet fever. It's followed by extensive formation of bullae and exfoliation similar to that seen in burn patients. Toxic shock syndrome is another cutaneous manifestation that can be caused by staphylococcal endotoxins. These exotoxins, are referred to as superantigens because they have the ability to cause widespread antigen-specific activation of T lymphocytes. Toxic shock syndrome is accompanied by fever, hypotension, multi-organ dysfunction, and a diffuse sunburn-like rash that appears early on in infection. It's important to remember that toxic shock syndrome can also be caused by exotoxin-producing group A strep pyogenes strains. Clinically, the patient will present with cellulitis that progresses rapidly. The portal of entry for strep pyogenes-associated toxic shock is typically the skin, whereas with Staphylococcus aureus, there's various routes of infection that progress to toxic shock. Scarlet fever is the last form of toxin-mediated cutaneous disease, and it's a form of group A strep infection that can occur when the infecting strain produces exotoxin. It occurs primarily in children with pharyngeal infection. Fever is typically present, and then the rash begins on the chest and spreads outward. It appears as a red sandpaper textured rash that typically doesn't involve the face. The patient may present with a strawberry tongue that appears bright red with dots of white papular. During the convalescent stage, peeling of the skin occurs, especially on the hands and feet. So in terms of diagnosing the various skin manifestations, there's a variety of diagnostic methods that can be helpful in determining the causative agents. So frequently swabs will be submitted that are taken from the surface of broken or ulcerated skin. And as we've mentioned before, swabs are usually the least coveted sample type because often it will also grow colonizing or contaminating bacteria. So deep aspirates or biopsy samples are better specimens when trying to determine the causative agent of skin presentations. With obtaining laboratory specimens, if pustules or vesicles are present, the roof or crust of them should be removed with a sterile blade, and any pus or exudate should be gram-stained and cultured. When working up the specimen, gram stain should be performed if bacteria are suspected as the causative agent, whereas Calciflora white or lactophenylcotton blue should be used if fungi are suspected. And then, of course, if mycobacteria are suspected, acid-fast stain should be used. When culturing, appropriate media should also be selected. So enriched media should be used to obtain identification of all possible organisms, and selective media should be added as well to detect specific pathogens. So overall in this chapter, we covered a lot of organisms and disease states and infections that we've seen previously. But some important things to remember in regards to skin and soft tissue infections are that the normal skin flora can be involved in infections if the integrity of the skin or the immune status of the host is compromised. So we saw in a lot of these skin infections, Staphylococcus aureus, particularly methicillin-resistant Staph aureus, and Streptococcus pyogenes, or group A strep, are important causes of various clinical presentations, especially causes of Pyodermas. It's also important to note that sometimes the organisms themselves are not the causative agent of the clinical manifestation, but it's actually the toxin released. And these help the organisms evade host defense mechanisms and can result in severe manifestations of infection. So again, looking back at the causative agents of Staphylococcus aureus and Strep pyogenes, they can cause immune-mediated complexes or toxins that result in the skin presentations. And finally, even though discussed briefly, it's important to remember that the method and site of collection, along with the quality of specimen, are important to consider when evaluating skin and soft tissue infections, along with the clinical context. So, for example, if you have a normal, healthy individual growing a coagulase-negative staph from a wound culture, this needs to be assessed whether it's true infection or colonization, opposed to a burn victim growing a coagulase-negative staph from a wound. And this would be seen as being clinically significant because the patient is immunosuppressed.